Good afternoon, everybody, and welcome to our second full joint commissioning board. A warm welcome to all our political leaders, clinical chairs and accountable officers in the room, as well as representatives from the partnership. We did full introductions last time, so in the interest of saving 10 minutes whilst we go round, everybody's got nameplates in front of them that the camera will be able to pick up. So maybe if we just move on to apologies. So do we have apologies, Lindsay?
Yeah, I'll minute them.
You'll minute them, thank you. Okay, in terms of urgent business, there aren't any that I want to raise which aren't covered by the agenda. So let's move through to declarations of interest. Does anybody have anything they want to declare as a potential interest for agenda items today? Okay, if one does arise during the course of the meeting, please feel free to raise it. Okay, so we've got the minutes from the meeting that was held on the 18th of December. That was the last full JCB. So first of all, can we approve those minutes as an accurate record? Agreed. Okay, thank you. A couple of brief updates. So one was that last time in the recommendations there was a specific one for Hayward, Middleton and Rochdale CCG. That's now been satisfactorily resolved and the CCG has signed off the full terms of reference for the Joint Commissioning Board. And also work with regard to the delegation of relevant local authority functions has commenced. The board will be kept appraised of those as in development, and there might well be a relevant points of discussion to have in terms of Sarah Price's presentation later around population health. Hopefully we'll make quite a bit of progress between now and our next planned full JCB in June. Okay, moving us on to a summary from the two JCB executive meetings that have been held since December. Rob, do you want to introduce your summary paper, please?
Thank you very much, Tom. So as members I know are aware, in the months where this full JCB doesn't meet, there is a JCB executive meeting that takes place, and to ensure appropriate governance is in place, we are providing summaries of the two meetings that have taken place between the last full meeting of this board. So I'm happy to take that as read and invite any comments or questions from members on any of the items contained within that update.
Okay, thank you. Sarah, can I bring you in at this point, please?
So it's just to update members of the JCB that a lot of work's taken place on the Improving Specialist Care programme since the board last met. And in the minute, you'll remember that we were planning to have a workshop this week on the 21st. And I just wanted to let everybody know that who hadn't already heard that we are planning to defer that until May. And the reasons for that are there's been a lot of, as I say, positive discussion. I think some of the feedback coming out of that needs a bit more work, but although very positive. I think some of the advice that we've received is that potentially, while low risk, there may be some issues with running the workshop at a time when we're about to enter purdah for the election. So I think it was felt, particularly by our council colleagues, that perhaps it would make more sense to delay that until May. But just to reassure you that the work carries on and we'll be coming back to JCB with the options for that modelling as soon as we can after that.
Okay, thanks, Sarah, for that clarification. Any questions for Rob on his paper? No? Okay. Obviously, it's the first time we presented this paper in this format. Did people find the format helpful? Was it the right level of detail? Yeah, nods around the room. Okay, thank you. So we're asked to know, which we duly do. So I'm going to take us on to our next paper, which is the prospectus for taking charge. John, are you presenting this paper?
I am. So this is a paper that's on a journey through to Partnership Executive Board and then into the full public domain. We adopted our first plan under the devolved framework, which came in 1st of April 2016, which was taking charge, and we're still in the midst of delivering that plan. But in light of the fact that there have been quite a lot of changes in the external landscape over the last 6 to 9 months, we judged that it was important to restate and to update our vision of where we're going as a health and care system, and to begin to map out to enable both public and workforce engagement, begin to map out what some of the parameters and opportunities of the next stages of our development might contain. This has been brought into sharper focus by the publication nationally of the long-term plan. The long-term plan requires that every integrated care system, and we are both a devolved and an integrated care system, every integrated care system should publish a 5-year plan. And we will need to publish ours, as with the rest of the country, in the autumn of this year. So what we will be doing effectively is preparing a fresh 5-year plan that will overlap in terms of its first year and the final year of our original plan. So over the last 6 months, we've done a lot of work as a system in drafting this prospectus. Many people have been involved in its development and contributing to its shape. We've generated support papers, workshops, away events and so on. And this is now the synthesis of all that work, also taking into account the content of the National Long-Term Plan. It has 3 big themes within it. The first is our desire to develop a population health system for Greater Manchester. We go beyond the parameters of the NHS long-term plan. What we are doing is fundamentally about economic development and public service reform and the bridge between them. It's deeply concerned with inequalities and with tackling the social determinants of poor health and getting to a situation where our population in greater numbers is demanding good health. And we are creating that climate in which people can live healthier and happier lives. The second big theme is a sustainable health and care system. What we have in Greater Manchester through devolution is earned autonomy, and it can be taken away from us. And one of the key tests in terms of our stewardship of the GM system is whether we can truly say that we are developing a sustainable system. And that starts with the NHS Constitution, but it also applies to social care as well in terms of, for example, social care quality. So whether it's the quality of provision, whether it's about meeting waiting time standards and access standards, we have to do the basics well. And that, of course, includes the money. We've got a very good track record in our first 3 years of stewarding this system in terms of looking after the pounds and pence. And while we can celebrate the fact that we've managed to more than break even on the NHS side, we're always cognizant of the fact that that is in part because of the very hard work and diligence of our local government colleagues and the resources that they have had to take, not least from reserves, in terms of maintaining social care provision within their localities. The third big theme is unlocking economic potential. And this, in some ways, is the most exciting of all because it is becoming very clear through the work, particularly of Health Innovation Manchester, that the interface between a unified population health system of 2.8, 2.9 million people, a powerful academia, and the opportunity that industry brings is creating an environment or a climate where innovation is flourishing. Health Innovation itself now, Health Innovation Manchester has a portfolio of over 100 projects covering digital, genomics, life sciences, medicines, telecare, telehealth, etc. We have an extraordinary opportunity in the next 5 years through our industrial strategy, linked to the National Industrial Strategy, to make GM a crucial, not only national, but global centre for health innovation. So I commend the prospectus to you, and we ask for the Joint Commissioning Board's support for it as we prepare for final approval and publication into the public domain.
Okay, thank you, John. I'm going to open it up now to comments or questions. None? Okay. Well, I think that's probably a sign, John, of how well socialised this has been so far. And I mean that actually quite sincerely because I think we've all had numerous opportunities to comment, provide feedback, and it's been very much co-produced. So I think we're all at the point where we're happy to complete the recommendation, which is to approve from the JCB the final draft of the prospectus. So, okay, thank you. Okay, so I'm going to move us now on to the 100-day commissioning review. Perhaps I can look to Ian Williamson to introduce, please.
Thank you very much. I hope this report is as well received as the last one. Thank you. I'm going to introduce this report on behalf of myself and Sarah Price, co-lead for this work. Before I finish, I'd like to invite Dr. Sally Johnston to say a word as well about it, because she's had a clinical lead role in relation to it. The JCB executive has had updates on this work in previous months, and previous updates have been well received, and the report references workshops that we've had, including a recent one earlier this month. Just a reminder, I know we don't need to be told this, but I sometimes find it helpful to remind myself that this is a means to an end, not an end in itself. We are aiming to improve the health and well-being of the people that we serve, and we know from the report that John has just highlighted that we still have massive challenges in Greater Manchester. So we are not improving the commissioning system because we want to improve the commissioning system. We want to do it because it is a means to an end of improving the health and well-being of the people that we serve, the poor life expectancy, the childhood poverty, the challenges of people with long-term conditions, and, for example, of those people out of work, to encourage them to get into the work, to reflect the range of challenges that we have. We had initially hoped that the full report would be in front of the JCB this month, and I just want to explain why that isn't the case. Although the content of the likely recommendations, which has been well shared, is I think, well received and understood, what has become clear is that much of the work that we've been doing has impact on other parties and partners within Greater Manchester, and therefore it's important that we have some further discussion to ensure that our respective roles are clear as we move forward. So, for example, that the role of the Joint Commissioning Board, this group, fits well with the role of the Partnership Executive Board that sits above us. So we've got a little bit more work to do on that. We have a meeting tomorrow with John, with yourself, Tom, and other senior leaders from the different partnering groups, and I'm hoping that we can make progress there. And before I finish, I'll just say a bit about timing and next steps as well, if I may. I'd like to emphasise that there is obviously a close fit with the previous item with the prospectus, because this work is referenced within the prospectus as one of the key work streams within it. I expect that the final report will also, as we've discussed, explain the difference that we have in Greater Manchester from many other parts of the country. Because in many other parts of the country, as integrated care systems are pursued, there is a consistent pursuance of often the merging of CCGs into bigger organisations. And we in Greater Manchester are different, because we believe that there is tremendous strength, and we believe there is greater strength actually in place-based integration of health and care and health with other partners in each of our 10 boroughs. And the report is likely to emphasise that. Crucially, though, what we still need to demonstrate is that we can deliver better outcomes, we can deliver the constitutional legal standards that we are responsible for, and we can deliver reductions in cost, including running costs, where relevant as well. So we do need to differentiate ourselves from the country, whilst also demonstrating that our performance can be as good, if not better. Penultimately, I expect that as the report develops and hopefully arrives next month, that some of the key themes that we've been discussing will become visible again. So, for example, as we've discussed, the desire to move further and faster in each of our 10 localities around the development of our commissioning arrangements and the development of our local care organisations. So we need to have bigger and better impact to improve health and wellbeing quicker. the links to population health, which I think we're hearing about later on the agenda, are very strong, and our determination to commission acute hospital services and, where relevant, residential and nursing home services as well on an organised basis across the whole of GM, so that we are getting the benefits of doing things once where it makes sense to do things once, whilst we're also retaining the benefits of doing things locally in our patches where we are closer to the people that we serve. And all of those priorities need to be underpinned by a strong and effective Joint Commissioning Board, and we think a strong and effective Joint Commissioning team, which I expect there will be recommendations which propose a continuance with obvious necessary changes where relevant to the work of the Greater Manchester Commissioning Hub that Rob has been heading up for us in the period to date. So just a word then, if I may, about timing. We hope that the discussions that I've already alluded to will take place intensively over the next 2 or 3 weeks. If it's possible then, subject to all the partners in GM being on the same page and in agreement, we'd like to see if we could bring a final copy of the report to the JCB at the earliest opportunity, in advance of it going to the Partnership Executive Board. So through you, Chair, in a moment, I ask if it's possible to consider having a special additional full meeting in public of the Joint Commissioning Board, potentially relatively or a single item agenda, in order to consider the results of the Future Commissioning report if it's available in early April. So it's an update report today. I think good progress is being made. Some further work is needed, but confident that we're making good progress, and thanks to everybody concerned. If I can then ask Dr. Johnson.
So I'm going to suggest that we just hold that thought about how we're going to sort of manage timescales moving forwards. Let's just finish the presentation of where we've got to so far. So I'm going to bring Sally in, and then I'm going to go to Sarah. So Sally, please.
It was a great day at the end of February, and all 10 localities were very well represented. It was interesting to me as a clinician to see how actually commissioners are grappling to find the right solutions for us rather than solutions that make our lives more difficult, because sometimes as frontline GPs we feel that that's sometimes what goes on. All the recommendations that we brought last time from the JCB were very well received. I think I see the primary care networks as being a smaller version of GM and the CCGs. The recognition is that small can be really, really good for certain situations, but you have to work bigger for other situations, and trying to get the best for the patients can just mean trying to work out which system works best on different circumstances.
Thank you, Chair. Just to say that I think there's a period of time that we just need to take now to get some of those smaller things sorted out, and be happy to bring things back when they're ready.
So before we move on to looking at sort of potential timescales, are there any comments anybody would like to make on the work so far, the work that's been done? I think colleagues are giving a really helpful update, and the paper also gives us some clear guidance as to where we're up to. Okay, so you're all quiet today, aren't you? Okay, so let's just think about sort of timescales. So if we look at the recommendation in the paper we've received, it suggests coming back to a full JCB meeting in June, which is 3 months away. I, as your co-chair, have some concerns about waiting that length of time for us to actually look to make an approval around what is essentially our future arrangements around commissioning. And I'd be really keen for us to think about, can we do that earlier? I mean, I guess one thing we need to be mindful of is that this isn't ultimately our decision. So the JCB, I think, would look to approve and make a recommendation around 100-day commissioning, but we would need to involve the Partnership Executive Board, and ultimately would need to go to the Health and Care Board for signing off. So just thinking through timescales, I think, Ian, you've suggested that there's a strong possibility we might be able to bring this back to April's meeting, which is proposed to be a JCB executive, i.e. without political leaders in the room. I really think if we're going to make a decision about this, then we need everybody in the room, so it might be that we need to consider a single item agenda on that day, maybe with a full JCB and then a JCB executive afterwards. At this point, we're just going to bring John in for a comment.
Yeah, so I'm sure we can work through these arrangements. The one thing I'm not comfortable with is JCB considering this in the public domain before PEB have had a chance to consider it privately. That doesn't seem right to me.
So I'll bring you in for comments on that.
I think that's entirely sensible. I suggest we pick up the practical arrangements offline, Tom.
Okay. I guess I just need an indication from the room that if it's appropriate and we've got everything in alignment by April, would colleagues be willing to attend for a single agenda item rather than defer this to June? Because I do realise it's an ask, and it might be that it's not ready to come in April and we may need to look at May. But I'm just looking for some support in terms of Tim.
Yeah, thanks, Chair. Again, just thinking of the New World arrangements, it'd be helpful if we can have a slightly more detailed briefing to take for our strategic commissioning functions locally, just so that broader partners really understand what this is all about, so that when we come to that meeting, whenever it is, people are really excited on the detail.
I think April, from a politician's point of view, is a notoriously bad month to make any sensible decisions, quite frankly. So I think we need to be careful about that.
Okay, what I'm hearing is let's just take our time and make sure we bring it back when it's ready to come back. So that may be before June, it may not be before June. It's unlikely to be in April, given pressures on political leaders in that month. Okay, so any further comments any colleagues want to make? No? Okay, so we've received the update, and in terms of the recommendation, I think if we can just caveat that it's formal presentation to JCB June 2019 or earlier as appropriate. So I think if we just amend that recommendation to include that. Okay, thank you very much everybody for your comments there, very helpful. I'm going to move us on to Steve Dixon. You're presenting the Improving Specialist Care Neuro Rehabilitation update.
Great, thanks Tom. This paper is an update paper in terms of the progress that we've made to date on the acute neuro rehabilitation case for change and business case. JCB in December, we did some engagement back with JCB in December where we reconfirmed approval and support for the case of change and the model of care. We're now in the process of working up a full business case that will come to JCB in June. Alongside that business case, we will pick up and fully answer some of the queries that were raised as we've gone through the engagement process on the neuro rehabilitation case for change. Namely, some of the issues that were raised that we need to ensure are fully addressed are the travel impact for patients, families and friends, and a full equality impact assessment, particularly for some of our vulnerable groups. The links with community services. So the full business case is around the hospital bed-based services, but that does have a dependency with our community neuro rehab services. So we will pull together a stock take on community neuro rehab at that time. And the full business case will include full financial analysis from both a commissioner perspective and also the impact that this will have on provider cost base in order to give assurances before we approve the business case in June. What we have done in the meantime from December and the paper in front of us today comes with a couple of areas that have been developed. Firstly, it's around selecting the single provider that will deliver the bed-based services. This paper articulates a set of criteria that have been developed for us to select who that single NHS provider should be based on clinical codependencies. The main drivers for the selection was that if we wanted a single provider to manage the hospital-based services across the 4 sites, the clinical codependencies with the major trauma centre and the neurosciences inpatient services, which are both delivered on the Salford Royal site by Salford Royal, took precedence in terms of recognising that, or recommending that Salford Royal is the only provider that would be able to deliver and provide the full bed-based neuro-rehab services. That recommendation has also, and discussion has also gone to the Provider Federation Board, who also recommend the selection of Salford Royal as the single provider for the hospital bed-based neuro-rehab service. The other bit that's covered in the paper is round the sites and the estates. So the original case that came to JCB in December was site agnostic, but did describe the current sites that we've got in Greater Manchester. The work that we've done over the past couple of months we've worked with McKinsey, who have developed the estates modelling associated with the wider Theme 3 and hospital work to make sure that what we're doing for neuro-rehab is consistent with the estates modelling for the wider Theme 3 work. What's been concluded is that the 4 hospital sites will remain the same. So in terms of impact on beds, what we're describing here is that there will be 10 additional specialist beds on the Salford Royal site. The number of beds at the Fairfield, Stockport and Trafford NHS sites will stay the same, but there should be fewer beds and fewer patients going out of area. At the moment, we've got a number of patients who go out of area for in private hospitals because we haven't got adequate NHS beds. So that, in short, is the bed configuration. The 4 NHS sites will remain the same. The bed configuration, the numbers of beds will stay the same at 3 of the sites. There's 10 extra beds at Salford Royal. The types of patients and the conditions that will be managed across those 4 sites might be slightly different than what's happening at the moment. So the paper in front of us today is for JCB to endorse the criteria and the recommendation that Salford Royal is the single provider for acute neuro-rehab, and to note and endorse the work that's been on the estate's configuration. The paper also covers a bit of detail in terms of what is going to be covered in the full business case, and the further ask of JCB is that they're comfortable with the information that's going to be included in the full business case, or highlight any areas that haven't been articulated that they would like to see in June.
Thank you, Steve. Any comments or questions for Steve, please? Chris?
No, Tom, I don't know if it's a typo, but under the community section, we're going from 10 community services to 12. And where are the other?
I think it might be the other way around, it might be a typo. When we started doing the business case, there were 12 localities because Manchester was 3.
3, right.
We've now got 10 localities. Manchester is considering its approach to community. Manchester is considering its approach to community neuro-rehab. Obviously, at the time of starting this process, there were 3 separate localities and 3 separate services. That may or may not be the case as Manchester goes through its local approval process.
Okay, thank you. And then a follow-on question from that, for the costings. Will they give an indication of the costings for the community services at the GM level and standards that everybody will be expected to commission to?
So the information that we have available is the amount of investment that localities are currently making, and the level of investment where localities have chosen to invest more. That information is available. What we're not recommending as part of this case for change is the level of investment that each locality has to make in community services. What we are saying is we have approved the standards and the service specification for community neuro-rehab and stroke services. It is up to each locality to determine how much it needs to invest to deliver those standards, because each locality is investing differently. Some are investing in voluntary sector organisations or in different services, so we will not be prescripted to say this is how much localities should invest. What we are saying though is that as a board and as 10 localities we have agreed the specification. The important bit is that the specification and the standards are met. Localities might choose to invest differentially to deliver those outcomes.
Okay, thank you, Steve. Ruth, if we can bring you in for a comment.
Sorry if I've missed this in the information you shared, but I wanted to say it really helped see all the standards. Clinically, that helped to land a lot of what we've discussed previously, so thanks for that. My questions were, and it won't be for today, but when we get the full story in June, was around ICU and the link in with that, because I guess that has some importance for this patient group. And then the other thing that just occurred to me as I was reading through the clinical standards was that these patients won't necessarily just sit under one specialist. So it was just thinking about the kind of combined care that a patient might receive, because if you've had multiple trauma, then I assume that you would at least be under an orthopaedic consultant as well as a neurosurgeon and possibly lots of other people as well. And it was just thinking about what those patient pathways would look like if people have still got multiple needs ongoing. So it'd just be helpful to sort of understand that a bit more at the next time that we discuss it.
Tim?
Yeah, thanks, Chair. Again, partly picking up on that standards question, I think what isn't as clear is the real standards for the out-of-hospital part of for the community elements of this pathway. And because if we don't deliver the standards in that part of the system, there's likely to be a blockage going back up through the rest of the in-hospital various elements, which will still lead us to using the capacity of places outside of Greater Manchester. So whilst absolutely respecting the place of the 10 places to deliver those standards in different ways, we need to be very clear that the standards must be delivered to help that flow through the system.
Yeah, great. Really helpful point, Tim. And we'll make sure that one of the features of the business case that I didn't mention is the sequencing of which bit of this we do first, because obviously we want a fully functioning acute bed base, but we also want a fully functioning community services as well. In order for us to unlock and realise the potential of the case for change, we need to have the whole system working. The business case will articulate the sort of sequencing and timing of which bits we need to do first and which bits are dependent on others. But absolutely key is the implementation of community services before we can unlock the potential of the hospital.
John?
Just a reminder on that we've already signalled that during the course of 1920 we will be including the development of the community base and the implementation of standards as a deep dive assurance issue through the normal GM assurance framework.
Thank you. Helpful. Ian?
Thank you. Just briefly, fully supportive of the recommendations. A more general comment which occurs to me from this paper and also other discussions we will have within the JCB, which is that I think as we as a JCB become more developed and more familiar with each other, then we will have to consider the choices that we have between competing priorities, both individually within our patches, which we do all the time, but also collectively. So we will at the moment be considering a number of issues and a number of proposals in isolation. I suggest that over time we'll probably need to have some method by which we are prepared to consider them in the round as to what will deliver the greatest benefit, for example. Thank you.
Okay, that's a helpful point, Ian. Thank you. Okay, any more comments? Okay, so the full business case is due to come back in June. Okay, so we will look forward to that. In terms of recommendations, if I can move us on to that. So there's 4 recommendations. The first is to endorse the decision-making process in selecting a single provider. The second was to endorse the recommendation of Salford Royal as the single provider, endorse the recommendation of site and bed-based configuration, and also the business case framework and the decision to undertake a full business case. Are we happy to approve all 4 of those recommendations? Yes, okay, thank you. I'm going to draw that one to a close. Steve, thank you very much for all your hard work on this and leading so well on this item for us to date. So we've now got approximately 30 to 40 minutes for Commissioning for Population Health. So for many colleagues in the room, when I've spoken to you offline, clinical chairs or political leaders, yes, we understand the importance of improving specialist hospital services, but also there is more to our commissioning intentions, and population health, primary and community care is a key focus for all of us. So we're really keen that we've got a significant amount of the agenda today devoted to this. So I'm going to invite Sarah Price from the partnership to lead the presentation. Thank you.
Thank you, Chair. So as Ian, I think, pointed out earlier when we were talking about our commissioning roles, a lot of what we're doing is trying to improve the outcomes for people who live in Greater Manchester. And sometimes it's a bit easy to forget about that. And I apologise in advance because I know often when public health people present data, it all seems a bit doom and gloom, but I'm hoping that there's some green shoots of improvement in some of what I'm going to tell you about, which will make you feel that we're working towards the right direction in terms of outcomes for people. So as we all know, Greater Manchester has a lot of challenges. Our 2.8 million, we've got significant people who are unemployed. We've got significant numbers of children who aren't ready for school. We don't have as good a life expectancy as other places in England. And we are dealing with multiple deprivations spread across our city region. So about a third of our population live in the 20% most deprived. But as you can see, it's spread in all of our towns across Greater Manchester. And I'm sure you know your own localities really well. But it's really important to understand that this is a pattern that presents itself across the whole of the city region. Did some work a couple of weeks ago to look at where we are as a city region compared to some of the others where metro mayors are working. And as you can see, if you look at life expectancy, this is for men between 2003 and now, our life expectancy is flattening out in a way that perhaps not everybody's is. It's London at the top, and the rest of us are struggling somewhat. And I think really gives power to our plan to work together in a more joined up way, a bit like Andy was talking about at the beginning of the meeting, and the power of coming together that could potentially address some of these challenges. And in fact, for women, it's worse than it is for men. So there's a lot of work that needs to be done to understand why that's happening particularly, but that life expectancy gap is growing for some of us compared to other areas of the country, and it's something that we really do need to address. So some of those discussions that we have about health inequality and reducing those are really where we need to focus our attention. And particularly if you look at healthy life expectancy, so this is the time at which, the age at which people start to become ill and need help and support. You can see that we have huge variation across Greater Manchester, but that all in all, apart from Trafford, we are below the England average. And some of our areas, like Manchester, Tameside, and others, are experiencing very poor health for extended periods of time. So if you're living into your 70s, but your poor health starts in your mid-50s, then it really does affect what the outcomes for you are going to be like in terms of your ability to work. So contributing to that economic potential of Greater Manchester, etc., are going to be limited if you're not well. So that's the negative. So what have we been doing? You'll remember from taking charge, we had huge ambition about improving the overall life expectancy to increase to regional average. We wanted to reduce health inequality significantly, wanted more children to be ready for school and to benefit from the development that's there for education and for getting a good job. And we wanted people to be healthy enough to stay in work, to have good mental health, and really be supported to have a really productive older age. So those are the sorts of things that we were looking at. And from that, we developed our population health plan. So as John pointed out when talking about the prospectus, we wanted population health to be at the heart of what we were doing. So we wanted to address those areas that we felt needed particular focus, and not just doing more prevention of the traditional form, but doing it differently by investing jointly across our system and taking really innovative approaches in Greater Manchester to build on what was happening in localities, but to test out what we needed to do at scale to see if we could get that population shift in terms of outcome. We've pulled together our plan in early 2017, and there were originally about 23 programmes in the plan. Of those, about 16 have attracted funding. Others are just happening because it's about redesigning how we work. But we want to, over the period of this work, to really start to build an evidence base for the cost effectiveness of public health interventions. What will work, what doesn't work, because not everything's going to work, but what will make a difference for our population. So some of you will remember that we made the case for investment through the Transformation Fund in this work, and we've been allocated £30 million through the TF. And the Population Health Board, chaired by Carolyn Wilkins, has allocated all 30 million of that now, and this is the breakdown of how that's been spent. So you'll see there's a significant proportion being spent on making smoking history. Smoking is still the biggest contributor to health inequalities in terms of our population and others. But there are big investments in things like work and health. So we know that having meaningful activity is really important to people's mental health. But in those wider determinants, having a job is absolutely fundamental to people's income, being able to sustain a strong and healthy life. So we've made investments in places that perhaps other people wouldn't traditionally have focused their attention. But all of these, I think, have got real benefit over the longer term. So just to give you a feel, we've been releasing various plans over the last 2 years. In July in 2017, we launched both GM Moving and the Making Smoking History programme. But we've gradually been focusing our attention on other areas. As I said, £4.5 million invested in health and employment, significant money going into health checks, food and nutrition, drugs and alcohol, etc. And just to give you a flavour of some of the things we've been doing. So moving on then, just to give you a bit more detail, in terms of making smoking history, I don't propose to go through this slide, but you may also remember that we committed to reducing smoking prevalence to 13% by the end of 2021. That would require 115,000, or a third of our smokers, when we started, to give up smoking. And if we were to achieve it, it would be the fastest improvement in smoking prevalence, both nationally and internationally. It would be faster than New York. So it really was an ambition. And so within a decade, we could really say that we had a tobacco-free generation within GM. And we've got a really comprehensive programme that addresses a number of issues, right from making sure that we've got illicit tobacco being addressed, reduction in access to cheap and fake tobacco, to try and enforce tobacco regulation, etc., right through to very targeted support for people in hospital, using or seeing tobacco as an addiction, the CURE programme, where we hope to be able to really support people out into the community with nicotine replacement and really help them on their way to becoming smoke-free. Last week we launched our latest campaign, which is targeted at people who segmentation would suggest are ready to give up smoking, and it's very much focused on people who are in that position. And you may have seen some of the posters. They're called You Can is the name of You Can Do It, and we've got lots of people who've managed to give up smoking talking about their experience. So we think this will help us. So Working Well, I've mentioned, that's launching tomorrow in Oldham. I think Councillor Fielding will be leading that. Really exciting project, and I think lots of people across the country will be looking at us to see what benefits we're able to bring forth from that, building on the very strong Working Well programme in Greater Manchester already. So the point about needing to support people to stay in work, so this is very much focused on those who are at risk of falling out of work, largely due to poor health. So out of the 236,000 GM residents who are out of work, 150,000 of them are out of work due to poor health. That's MSK issues as well as mental health and others, but huge reasons why we need to address this issue. This is the programme for getting health and employment across GM, and this particular programme figures on that early help. So we hope to be able to support people at risk, as I say, when you present to your GP with health problems that might mean that you can't continue in work. We hope to be able to support people to be able to continue, whether that's through rapid access to physiotherapy or to IAPT or other important services that will allow people to stay in work. And we're hoping that in the 3-year programme we'll be able to help 11,000 people. About 80% of those would be people who are currently in work, but about 20% of them would be up to 6 months unemployed. There's very good evidence that if you don't get back into work quickly, you really struggle to get back in at all. So this really is about trying to be much more preventative in our approach. And given that large numbers of businesses in GM are small or medium-sized enterprises, they really do struggle sometimes to be able to support people. So we want to be able to look at that as well. If you don't have an occupational health department, what could we do to help those businesses support their workers? Health checks, many of you will know that anyone who qualifies for a health check is invited every 3 years for a health check, and at the moment, although we have huge variation in the numbers of people who are identified as having risk from particularly cardiovascular disease, but others as well, we estimate that only about 50% of those invited to health checks actually attend, and there's over 500,000 people who are eligible. So there are significant numbers of people who are not coming forward for a health check. And we also know that many of those that do come forward are probably healthier than those that don't. So if we really want to address some of our health inequality, then we need to pick those people up. What we're proposing to do is to start a pilot, and we're just negotiating with the national team on this because health checks is a mandated national programme, about how we might do this. It would be to calculate the cardiovascular risk of our residents and then offer a face-to-face health check to those who are at highest risk of cardiovascular disease, and make a digital offer to those who are at lower risk. And we need to do some quite innovative work to think about how we'd capture some of the data that's required and make sure it gets back into people's GP record using a digital offer. But we think that there are ways that we could do this. So it would mean that the effort and the resource that we're spending on health checks at the moment goes to those at the highest risk, not those that perhaps are in a position to help themselves. There's a number of technical hurdles, and recording of information will be really important, but we're working on those challenges at the moment. In terms of GM moving, we committed that we'd double the rate of people who are active or who are very active, and we need 75% of those to be active or fairly active by 2025, yet another challenging target we've set ourselves. There are a number of ways in which we're doing that. A year ago, we committed to being a daily mile city region, and we've had about 50% more schools sign up for that, but we're not just looking at schools, we're looking at nurseries, we're working with businesses, and those are signing up for the Daily Mile as well. I'm sure there's more that we could be doing across the health and social care sector to demonstrate that we're healthy. Since last summer, we've been working with communities at a very local level to ask them about the sorts of things that they think would make a difference to improving physical activity for them. So real asset-based approach, working at a very local level to make sure that the sorts of things that we might help and support people with will make a difference. So some very interesting work going on there. And then at a city region level, really looking at walking as being the vehicle through which we will improve physical activity, and tying in with some of the work that the Mayor sponsored through his walking and cycling commissioner, Chris Boardman, and the Made to Move initiatives, and getting the social change that you need to sit alongside some of that infrastructure challenge to make a difference. The last kind of programme that I'm picking out is called Incentivising Healthy Lives, and we're working with Public Health England on a project to see whether or not we can incentivise behaviour change through the collection of points. And I know there's been smaller scale tests of this, not least in our smoking in pregnancy work, where we're looking at shopping vouchers across GM for those who are finding it hardest to give up smoking, and having some initial signs that this may be something that works. So this would be doing it on a much larger scale, using your phone to count your steps, or to ask you participate in quizzes with the ability to send out notifications to you to encourage you to go for your flu jab, etc., etc. The areas that we're going to look at initially in our 12-month pilot that will start in June is physical activity and smoking, so building on the CURE programme. When you come out of hospital, what else can we do to incentivise you to stick with the programme that you've got to help you support give up smoking? Some of the work on alcohol that we've been doing, we'd like to enhance that by encouraging people to take on answering questions about their alcohol consumption, and giving them information and encouragement to keep it at healthy levels. And in terms of the health checks programme, some of that digital offer we think we could tie in to an app like this. So the focus, I think we've just, some of you may have heard at PEB, we want to focus on those in the C2DE, probably more the C2D group, and we're going to segment the population in order to be able to encourage people to sign up for the programme. So I said at the beginning that there are some green shoots, and to some of the programmes, although much of what I've discussed is only just really getting off the ground, and this is very early data on smoking. We've commissioned something from a national survey called Smoking Toolkit Survey to get some initial analysis on what's happening in GM. There isn't GM data available previously. So this is the first 3 quarters data, and this is about whether the percentage of people who've made one or more quit attempts in the last 12 months. When we did the evidence review on our programme, one of the things we worked through was that in order that we meet that 13% target, we'd need about 40% of people to be making meaningful quit attempts in order that we could get the sorts of numbers through. And as you'll see there, a bit faint, but we're just about at 39.8% in the last quarter. So obviously we've got to maintain these figures, but we're really hopeful that we are hitting the sorts of levels that we need to. And as you'll see, we're significantly higher than the quit rates for the rest of England, which is the lower line. Because we've only got 3 data points, I'm not sure how reliable some of this is, but it does suggest that the solid green line is the 3 data points. The dotted green line is our trend data that or trajectory that we need to hit that 13% by the end of 2021, and the grey line is England. But it does look like we are beginning to move towards the England rate, which I think would be absolutely fantastic if we can sustain that. But again, these are early figures, and I just wanted to give you a feel for the direction of travel that we're going in. Some of the other areas, as I said, 350 additional primary schools are now signed up to the Daily Mile. In terms of oral health, in our targeted boroughs, there are 4 boroughs across GM who have the very poorest oral health, high rates of children having tooth extraction due to decayed, missing and filled teeth. 90% of health visitor reviews now include oral health packs, so that's giving out toothpaste and toothbrushes and helping people understand that they need to brush teeth right from the eruption of those teeth. And 722 early year settings are participating in that supervised brushing scheme. So when children are in nurseries, etc., they are being helped to brush their teeth. And we have got an increase in access to primary dental care services by 2.5% on the previous 12 months, which feels like going in the right direction. And on smoking in pregnancy, since our programme began, we do have high rates of smoking in pregnancy in GM. The proportion of mothers known to be smokers at the time of delivery has reduced twice as quickly as the national average. So we do think we are providing the sort of support that might be helping people move forward. So just to say that from a population health system point of view, we need to be looking at wider determinants of health as well as behaviours and lifestyles. We need to be working in communities to support people make different choices, and we need to participate in that broader public service reform. And so some of the work we're doing around contributing to things like the spatial framework, the industrial strategy, the work around the model for public service are all things that will contribute to this overall approach around population health and making sure that we move forward in a positive way. And if you look at some of what we're trying to do, we think we've got programmes that are addressing things in each of those quadrants, which will give us that system approach that John mentioned earlier. So I leave it there. I'm happy to answer any questions.
Okay, thank you, Sarah. Certainly, if I look in my own locality, Salford CCG, we spend quite a bit of time in our governing body discussing the wider determinants of health, and we're really excited about the opportunity of our further integrated commissioning arrangements with the council from April in terms of being able to play into that space. So I'm sure that your presentation has resonated with everybody in the room. Can I bring in colleagues for comment, please? Sue?
Sorry, I hid my thing. Thanks, Sarah. I think what's really interesting as I was listening to that is that we've had the opportunity in Greater Manchester of a transformation fund, but really in this room, I would hope that what we do would be to do what we do in our localities, which is consider the whole of our spend and how much of that should be directed towards prevention rather than that little bit of foam on the top of the coffee that is the transformation fund, which gives us that little bit of allowable extra. So I would hope that in future meetings of the JCB, we really start to think, and a few people have mentioned today prioritisation, but really start to think as Greater Manchester, where do we want to prioritise our resources and our overall budgets together, and what are the areas where it's best doing that, because clearly population health and prevention is a really important part of that for all of us.
Okay, thank you, Sue. John?
Yeah, I think of the transformation funding more like a new type of coffee granule that's permeating the water rather than the foam on top. The point is that we're trying to demonstrate proof of concept by trying new ways of working and demonstrating and evaluating whether they work or not. And what our hope is that by working out what does work, there is then an opportunity for the commissioning system as a whole to adopt those new ideas and make them mainstream.
Thank you. John Murray?
Yeah, I was just thinking my partner's in Colombia at the moment. I must encourage her to bring some of that coffee back, actually, to try and alleviate what the debate we're talking about. I want to actually sort of broaden this debate a little bit, because I'm very impressed by what we're trying to do. I think it is the right approach to take to these particular issues. But I'm also acutely aware that we've got to set it within a wider context as well. I know that people from Salford, right, which I want to encourage to stop smoking, I'm acutely aware that if they're living chaotic lives and they're having real difficulties, I think, by the way, me going around to them and knocking on their door and saying, have you thought about giving up smoking as well? I'm likely to get pretty short shrift, actually. And I think it is about how do we help to people to organise their lives, and more importantly, understand the psychological barriers to some of these things. And I'm speaking of someone who has just been reminded I must go and get my diabetic health check in a minute, actually. But the fact remains that why do people not go to health checks? Part of the problem is because they don't want to receive the answer. And part of what we need to do, I think I'd suggest, is to reassure people that even if something is found, not working as well as it might do, that we can do something about it. And I just think that we don't do enough about reassuring people what the purpose of the health check is, rather than simply demanding that they take it.
Yeah, I think a good point you've made there, John, in terms of how we can best work with our population to deliver on some of the work that we're really keen to achieve, and one of those is about health checks, and it's an opportunity. But at the moment, in my own experience, the people who are most likely to take up a health check are the ones who are least likely to benefit from it. So I think, Sarah, in your presentation, you touched on a more targeted approach, and I think there's great merit in that. So we'd be interested to work with you on that. Okay, Chris, you wanted to come in.
I did, but you just pinched me thunder, because I was going to applaud the targeted approach as well, because for far too often, everybody gets the same, irrespective of the likely outcome of it, and targeting into the higher risk and then a separate offer to the lower risk, I think is a fantastic way to go. But you pinched my thunder. The unworried
Okay, so
unwell.
I'm getting a few nods from clinical chairs, so I think we're all potentially supportive of you there, Sarah. Keith?
Yeah, I just think in terms of this, we're not really answering the question of, because we're talking about things we're going to do for people or do to people, and what is the connection with people and connecting them to communities and using asset-based approaches. And I often get concerned about, making smoking history and all that, because actually the people who have the worst health and the lowest life expectancy are primarily in our deprived areas. The number of unemployed people in those deprived areas are higher than everywhere else. The likelihood of smoking in those areas is higher. The incidence of alcohol problems or alcohol addictions are higher in those areas. And children are more likely to be not school ready. So I don't want us knocking on a door saying we're going to deal with your smoking, and and the other thing is physical activity is likely to be the lowest. So you don't want a series of programs that are addressing issues in a silo mentality, because actually what you're talking about is working in those areas across the whole range of things. So yeah, if you're working with somebody who is in a deprived area, who is unemployed, who does smoke, who does abuse alcohol, whose children aren't school ready, there's a whole different approach to dealing with that in a whole system manner. And I think, if we're going to really address population health and improve it, we need to adopt some kind of system like that.
Okay, Keith, a point really well made in terms of coordination of approach. And Sarah, I'm going to allow you the opportunity to come back at the end, but I've got 3 more colleagues who want to come in. So let's take as many questions and comments as possible, and then we'll come back to you. So we're in next, please.
Thanks, Chair. I was really encouraged to see some of the green shoots in our population models there. There's a clear articulation of the health gap between our region and London. Yes, we understand that. But I think this is a little bit point picking up from the last speaker. It's about the gap that we have within our locality. What I'm interested in, are there any green shoots there which are actually closing those gaps within our localities, the health gap within our localities? So I'd really like to understand those green shoots, if there are any, because certainly in our locality in Bolton, this health gap between the deprived and the affluent areas is really stubborn. It's very, very hard to shift that, and all the initiatives that we have done are not really pointing to in the right direction. So if there are any green shoots in any of the localities where they've been successful to shift this, I'd love to understand them.
Okay, thank you, Warren. A really good point about health inequality is one that we're all only too familiar with. Carolyn, please.
So it's to build on a couple of the comments that have already been made, really, but also a reassurance that this is absolutely integrated into the way that we're working. So we are in Oldham the beneficiary of a number of these strands, you know, the dental activity, smoking in pregnancy, and because it's then implemented with us, it's not being done to us because we are the Health and Social Care Partnership, but their articulation of these programmes in locality is for us to then work to make sure that they're integrated in the work we're doing more broadly. So, for example, on the dental work, we're looking at those areas across Oldham where this is most needed, and actually we're seeing really significant improvements in performance and definitely a narrowing of those inequality gaps, in the same in terms of cessation of smoking in pregnancy. And I think that's the real strength of this, is in the way that John says, this is proof of concept, but it's our proof of concept working in with the grain of how we're developing our new system, not being stuck on top of it, and that's the real strength of it.
Thank you, Carolyn. Bev?
Yes, I suppose it follows on quite nicely, because I think some of the points that have been made, I think particularly both Sue and Keith, in a sense, I think sets down the challenge that faces JCB and what is the role of the Joint Commissioning Board going forward. Because I think if we're to think about either some of the financial aspects, so post-transformation fund, what that means for commissioning, and some of what Keith's talking about how we connect that and embed it in the work that's happening both in localities but co-produced with citizens, I think the challenge for us will be to square how we make decisions of services and interventions that are appropriate at a Greater Manchester level and those that which either facilitate or support what's happening at a locality. So I think it's a really kind of interesting question that will no doubt face us for any of the issues, but I think particularly for population health. And I also just want to say I think it was good that much time has been spent talking about the wider context, so things like working well and the connections between wealth and health, because I think contrary to the easy opinion at times that any work is better than no work, actually a lot of the economic evidence suggests that that's simply not the case in terms of it has to be good quality work, and actually that connects itself into pay and conditions. You know, some of the things that have come out of the independent prosperity review at a Greater Manchester level shows the benefits of good work, not just any work, and the connectivity between people that are in and out of work with long-term conditions and quality. And then the final really was just an ask. If obviously we didn't receive any of the presentation in advance, so I'm sure we'd all appreciate it being circulated to us. And I think it's always just good to have a little bit of information that sits behind, I think, what has been a very interesting conversation, but always brings a little bit more depth when we've got papers.
Okay, thank you, Bev. Lindsay's noted that. We'll make sure the slides are made available. And you've stolen my thunder, because that was one of the challenges I was going to set ourselves around this agenda, is how we can work as a joint commissioning board most effectively, and in particular between local authorities and CCGs across the 10 localities. Jeff, you wanted to come in.
Thanks. Really encouraged by a number of colleagues who have emphasised the importance of targeting population health. I think we need to build on that. So for all the great examples we've seen today, it'd be great to have a toolkit. So whatever intervention we are deploying, how is that best deployed in a targeted way? How is it best deployed in a way that's empathetic with the people that you're trying to help, so they help themselves? And in particular, how do we make sure that those interventions focus on the economic well-being of those people that most need these interventions? And I do think we need to focus on in-work poverty as well as unemployment. So I think we can build on this and build a practical toolkit, because I've actually found it quite hard over the years to get public health colleagues to accept the notion of targeting. if we are in agreement, that's what we need to do. Let's be serious about it. And also let's actually measure the amount of money we're investing in a targeted way versus a universal way, and understand, is our investment going in the direction we wanted it to?
I'm going to bring John in, and then Sarah, I'm going to come back to you for some comments in terms of all the different things that we've heard. Lots of really valid points, I think. One or two I'm going to pick out. Continuing challenges around health inequalities, a coordinated, targeted approach to helping the people most in need, and how we can deliver the Jeff and the Keith test, and then where the JCB our role going forwards in terms of supporting this piece of work. So, John?
So, in the absence of Alan Dow to be here for the tongue-in-cheek, it's nice to have 40 minutes discussing health without mentioning hospitals. And the reason why we do that, of course, is that the evidence says that secondary prevention in primary care, community care, is still the fastest way to reduce health inequalities. And that's not the full quote. The full quote is focused secondary prevention. So very keen to endorse the approach that we are going to be targeted. We are going to use technology. The thing for me is that in order to get the real changes that we need, the limits aren't going to be the technological and even the IT limits. It's going to be our appetite to go after the hard to reach populations and to work out how we partner with them. I'd like to, again, do an advert for oxytocin, which is the chemical that two humans release in their brains when they sit down and discuss a shared purpose. And I think we have to be really careful as we embrace technology that we do get people sitting down with people to discuss people's problems, because that's the thing, and I think that's a strength of Manchester. Really struck that we always compare ourselves to London, but Sarah, those statistics that London only have a 22% representation of the bottom fifth percentile, whereas we have 36.3% of our population. That's who we're about. If we don't get into that population, we might still be able to end the year with green shoots on our figures, but if we don't get into that really vulnerable population, we're not going to actually change the long-term metrics of the system. And so I'm very glad that Sarah and the rest are leading this work, because I know that's exactly the population they want to see. I just think that we have to hold ourselves to account about that, because that is the challenge in GM.
Okay, so Sarah, with that challenge, good to get your thoughts.
Thank you. So I absolutely get the challenge of the balance between what you do at a very, very local level and what you might do at a GM level. But I think the answer is you need some of both and something in between as well. So some of the programmes that we're really pushing forward are about the things that might make a difference because you can change policy at a GM level. And some of the things like the physical activity work at the moment is down in community centres with very small groups of people talking about what's going to make the difference for them and them designing what their intervention might need to be. That's work that we've got £10 million from Sport England to really push forward, and so we want to really build on the strengths of local communities. But where we have seen, I think it's really important to offer people help and support and advice if we can give it. So one of the things that we did do last year was fund a pilot in Salford in social housing, where we gave out 1,000 e-cigarette kits. One of the reasons that lots of people say that they don't use e-cigarettes isn't because they don't believe the evidence or whatever it might be. It's because they can't afford it, because it's too expensive. That you kind of think it's weird because they're spending a fortune on cigarettes, but they're spending that in small parcels of money, not in one big chunk up front. It's over £50, I think, for a vaping kit. So we gave out 1,000. They went like hotcakes, if I can put it like that, and we got over a 60% quit rate from, I think it was 64% quit rate from giving out those 1,000 kits. So that's much, much higher than you get from other things. And so I think there is a demand out there. People want help and support. We just have to make sure we give it to them in a way that makes sense for them and that helps them to make choices that lead to healthier outcomes. So I think the the balance is that proportionate universalism, dare I say it, where some things you do for everybody. So you create the environment where smoking isn't something that we would want to do, but you have targeted approaches within that pick up populations that find it harder to change. So I think we can certainly give you more information on the background to some of the programmes that we're running if that's of help to people. I think the JCB role going forward would be to really think about that investment balance and about how much in the longer term you want to start to push towards more primary prevention as well as secondary prevention, and how we balance that off with need at the present time. I mean, talking about homelessness earlier, you know, those are people sleeping on the streets with extreme need, but could we have done more for them when they were at risk if we'd picked them up through when they were at work and they were falling out of work because of stress or mental health problems or drug addiction or whatever it might have been, could we have helped them at that point? So I think looking at those wider determinants is really important context, thinking about how we as a system address those issues, and then thinking about the very specific things that might make a difference to our population if we can.
Okay, thank you, Sarah. And I guess moving forwards, in answer to Bev's point, we're looking at phase 2 of the Joint Commissioning Board, which is when local authorities will be able to delegate certain decisions into the JCB, and that will give us some real opportunities, I think, around some of the key items that we've touched upon today. So this is a piece of work in progress, and I think it's incumbent on myself, Linda, Rob and colleagues to make sure that JCB really helps drive forwards this agenda. So lots of supporting nods around the room, which is great to see. So our final agenda item is really for noting. It's a Director of Commissioning update. As part of our governance structure that reports into our full JCB. So Margaret, is there anything you want to particularly pull out of the report for our attention, please?
Thanks, Tom. Yeah, probably just 3 things. As you say, this is the first report under the new governance structure for JCB. And within that, within Directors of Commissioning, they also have oversight now of 2 other groups that formerly went to Association of Greater Manchester CCGs. That's the Effective Use of Resources Policy Decision Making, and also the Clinical Standards Board, which some colleagues may know as the Greater Manchester Medicines Management Group. So those groups now formally report to GM Directors of Commissioning, and decisions around policies are taken at that group. And essentially, in terms of both of them, it's around trying to get a consistent approach across the conurbation, whether that's for effective use of resources for drugs or clinical procedures. There's 10 of us, we all start at different positions, and the remit there is trying to get a consistent offer. So that now comes under the Directors of Commissioning and is referenced in the report. I think it's probably worth saying that the Clinical Standards Board's quite sort of well regarded nationally, and often we have regional colleagues sit on that group that often piggyback on work that's actually been initiated in Greater Manchester, but certainly the work programme for that, there's some really good work that's going on, but things like, I'm hoping in my next report I'll be able to say we've done some work that we've got a consistent approach to this sort of over-the-counter policies, but also we do know that one of the big things on that work plan is antimicrobial prescribing. Whilst there's some really good elements we're really good at in GM, there's that particular one where we absolutely need really focused work, and that's front and centre of that work plan. I think the second point, Tom, I wanted to mention is just to give a sense of the range of all the things that are coming through Directors of Commissioning. It often acts as a filter, and it often it has requests, if you like, to receive pieces of work for a commissioning viewpoint. And often I have to sort of marry up things that sort of may come from Health Innovation Manchester and ask them to say, do you know there's something similar going on the Strategic Clinical Network? There's something that links perhaps into some things of Theme 3. So there is a bit of marriage making around trying to get a synthesised approach. There's still across the whole health and care system and infrastructure, there is still lots of work going on in silos, and it is a useful filter. And the final point I wanted to raise in the paper is we've had our first joint workshop with directors of adult social services, so I'm hoping that we do that. We have at least a couple of those a year. The subject matter for the first one, which I think was successful, was about market sustainability, and that was both care home and care at home, and there were 3 work streams that came out of that, each with a Director of Commissioning and Director of Adult Social Services taking that forward, and I'm hoping that in a future report we'll be able to share with JCB some of the outputs of that joint working in the new integrated system. So those are the 3 points, and also the format, and similar to what Rob said earlier, the format of the report, if there's anything, how that lands and whether that there needs to be any amendments, I'm happy to take that on board.
Okay, thank you, Margaret, for your updates. Steve, you wanted to come in with a quick point, I think?
Yeah, just a quick one. So I welcome the content of the report, and it's really helpful to see the range of work. A specific comment, where a piece of work is actually going through directors of commissioning into this board, it would be incredibly helpful and actually be quite a useful piece of governance if actually we had directors of commissioning's views on pieces of work coming into this board, so we understood what they were as the governance came through. And you know, for an example, the neuro rehab, it's really important actually if directors of commissioning are discussing and reflecting upon pieces of work that actually this group understands what their views are, because it will help inform our decisions, I think.
Yeah. Okay, now I think that's a good point, Stephen. And certainly when we've done that in the past, the sequencing has been quite helpful, and it's something we perhaps should look to standardise. Okay, thank you, Margaret. If you've got any comments about the format, please do feed them back, but I thought it was a suitable level of detail, so thank you. Okay, I'm going to bring the meeting to a close. So we're next due to meet fully in June, but of course that may be open to change. So I'm going to close the meeting now, but ask colleagues to remain in your seats.